So a little bit about me. I do identify with the she series of pronouns. Originally from Puerto Rico, proud and loud Puerto Rican, but I'm checking in from Western Mass. Been living here most of my life, back and forth, actually. My background is within the peer work. I started off as a peer many moons ago. Um, as a peer specialist working in residential settings, I transitioned into outpatient settings as a recovery coach while I was doing my schooling for social work. And I'm currently a licensed certified social worker in the state of Massachusetts. And I specialize in co-occurring disorders, trauma disorders, and individuals who are justice involved. Um, Mainly because of my own lived experience. Even though as a clinician, I can't share my, experience as I would and leverage it as I would in peer work. I always know somebody, right? Or I have a friend when doing clinical work, and they, sometimes that friend might be me, and sometimes it might really be a friend, right? But I think that ability to relate is important in any space that we work with individuals experiencing, seasons in their life that are weighed with difficulty and oppression. So, for those of you who were here last week, just a little reminder, and for the new folks, right, that weren't here last week, just to share a little bit of my home, my forever employer, my supervisor and the director always chuckle when I say this, but when you buy that forever home, you find that forever home, they're stuck with me forever. They might not believe me; they think I'm joking, but we'll see, right? So C4 Innovations, or as we call it, lovingly C4, we're committed to advancing recovery wellness and housing stability for people who are underserved or under-resourced. And, the organization probably, I can say, women-owned, women-led, initiated in its history doing work for individuals struggling with housing stability. Through the years and the needs of the organizations that we collaborate with, we found, many other areas of support. And so we are committed to reducing some of those disparities and achieving equitable outcomes. We engage, support, and partner with service organization, communities, and systems to develop and implement research-based and evidence-based solutions that are person-centered, recovery-oriented, and trauma-informed. And you can, freely find us in our website, of course, C4 Innovations, and any of our social media handles. And now our hopes for, today is that when you walk away, you have the ability to describe the purpose, stigma, and bias and its components, right? Many times, both stigma and bias are real negative tools, right, that impact the way we show up for people and or perceive people in the world. I always say that bias, for instance, is not don't make us bad people, right? I always say that, bias are shaped by our experiences, both direct lived experience and or secondary experience by someone in our family, friend, social support circles. When we don't actively self-reflect on how they show up for us, it will negatively impact how we show up for individuals. But, you know, we also hope that you can walk away with the ability to correlate the impact of stigma and bias in the context of the whole person and their human self and why that matters. Be able to compare and contrast stigma and bias in your own genuine self and how it impacts the individuals, right? With that internalized impact that it has for individuals. Demonstrate person first language to reduce stigma. That's one of our biggest, and probably our primarily most important tool in dismantling stigma. And list at least two strategies for reducing stigma and bias. And that's going to be the fun part, right? Because we have a vignette or a scenario to really work through together. So oftentimes in the history of me doing this topic or power and privilege workshops, I want to first, encourage you to take care of yourself, right? I might say things that or talk about things that might activate some of your own feelings and memories from your own experience or from supporting the people that you work with. And so always prioritize taking care of yourself. If you have to step away, and take a breather, feel free to do so. When we do share, we want to, just for the sake of time and allowing everyone a share of the mic to stay on topic. There'll be many opportunities. One thing I accepted in my own recovery is that I don't know everything, and I embrace being a lifelong learner. Just like I couldn't work the Teams chat last time, this time I did work, try to figure it out, and now I don't see it on my screen anymore. So I have to rely on some of my colleagues from C4. I don't even know what happened, but anyhow, there will be many opportunities to provide your thoughts. You could use chat or unmute yourself. I would love this to be interactive, because based on your introductions, I noticed there's great knowledge in the room, right? Be it from a professional lens or a professional or lived experience. I'm happy to share the mic with you all to be able to share so that we can all learn together. If something does make you uncomfortable, right, and sure to address the ouch, I would love this space to be a safe space where if something is activated within you, you can share the mic, use the mic to share your experience so that we can, model behavior and how we take accountability for changing some of our language and how our language can really impact individuals. Commit to get out of your comfort zone into learning zone, and step into vulnerability, right? Be able to share what you want to share, of course, with respect for the room and everyone in it. Privacy to build trust. Don't share what specific members discuss within this discussion, but what you do learn, feel free to share, right? And minimize distractions. I know we all have um, busy lives, especially in this, human service world work that we do. So just try to be present. Any thoughts, questions, or anything you'd like to add that helps support you feeling safe in a learning environment such as this one? You can share on chat, but if you can unmute. All right. I could have sworn I had it, but I lost it. So the first thing we want to look at is components to stigma and bias. Looking at the different components, and then we'll look at the definition just to help us really get like that, just more like a high level context of stigma and bias. But first, we'll really focus on stigma just to be clear. And stigma is a combination of three components, and that's cognitive, which is more of those ignorant beliefs of not knowing or having an understanding of a certain population, situation, and so forth. The emotional, right? These negative feelings of dislike or fear that we have towards something, someone, or groups of people, right? And behavior or ostracizing and oppressive behavior that impacts how people are treated because of how we're sorted. And we'll get into that in the next slide. So different models of stigma propose different structures for the construct. One views stigma as a combination of three components, as I shared here, the cognitive with the negative feelings. And I'm repeating them because I have a little exercise already just to get us, our minds, warmed up. So the first of the three components is cognitive, right? Those ignorant beliefs, emotional negative. The emotional component reflects or speaks to negative feelings or dislike or fear. And behavior is ostracization and oppression. And others define stigma by the process through which it arises. This involves distinguishing and labeling differences, linking labels to negative stereotypes, placing labels on people in distinct categories, decreasing the status and limiting access to social, economic, and political power, which perpetuates rejection and discrimination in individuals that we might work with. Now, I will share some examples to get your brains flowing, right, warming up. And now I'll ask you to identify which of these components does the example line up with. And no pressure, there's no right or wrong answer, as some of these examples can fall in more than one component. So, for example,
all right, I'm in on my phone.
Oh, I'm happy you joined. You were able to join on your phone. Welcome. The first example is using slang or labels to exclude people or groups of people. Which of these components do you think using slang or labels to exclude people or groups of people fall into or might align with? Behavioral. Thank you, Christopher. Right on. Right on. Right. And it's because of that. It's more like that ignorant, I mean, not ignorant belief. It's more of the these labels that ostracize and oppress individuals, right? And they might not be validated with fact and evidence. And then what about assuming that someone with a mental illness or mental disorder is dangerous? Which component would that fall in? It can be cognitive, right? The belief of not knowing or that ignorant belief. Definitely also emotional, yes, because of that negative feeling of dislike, right? Especially around that term, the language used in the example, dangerous, right? What about our next one? Believing that people with physical health conditions are unable to contribute to society. Definitely cognitive, right? Because it's an ignorant belief. There's many individuals like myself with, mental health and a physical non-visual disabilities that can contribute positive and noteworthy things to society and their communities. Right on. Thank you all. Jokes about a physical or mental health condition or race, ethnicity, religion. What would that be? Emotional, cognitive, behavioral. Where would that align most? And I would even say cognitive, right? Because is this uneducated or ignorant perception of groups of people based on their race, ethnicity, religion, and mental health. What about this last one? Definitely too. Yes, you're absolutely right, Myra. Halloween costumes that portray people or groups of people in a negative way. Thanks, Rush. I like that name too, by the way. Definitely, right? And it really speaks to the intention, right, of why this individual has chosen this costume. Like, some examples that I always share with this activity is, thinking of, people in politics or people, that have this platform that have had pictures of them on Halloween with a black face, but are not from the Black or African American communities, right? What are the intentions? And with such a oppressed population, right? I don't think wanting to make a joke out of something like that is the intention, right? So it can definitely fall in all three. Well, thank you all. I figured out my chat so I can see your responses. Oh, there's it goes again. As I move my slides, that's what I've noticed. But we'll figure it out, right? There's widespread stigma surrounding people experiencing homelessness because they're seen as dirty, deviant, or immoral. It makes them more isolated and vulnerable. Such stigma promotes the passage of anti-homeless laws, criminalizing people for being on the streets. It also makes individuals experiencing homelessness more prone to be targeted or to verbal abuse and even violence. I can't even imagine, having a mental health disorder and or struggling with substance use and not having a stable housing, right? When we think about the hierarchy of needs, right? Housing, food, shelter, clothing, it's primary, right? And until we get to meet those, all the other ones would be or feel inaccessible. I remember doing an internship at OTP Clinic, Opiate Treatment Program, and driving up to the parking lot one day and seeing one of the clinic clients sleeping in the back of the dumpster. And it dawned on me, like, how can they, our participants, right, of the program, really put forth great progress, right? Positive, consistent progress. If we give them medication and we teach them coping skills, but when they leave our office door, the only thing they're thinking about, where am I going to sleep? What am I going to eat? Right? The priorities change. And it's not the individuals are that word that like, it's a ick for me, right? Non-compliant, this insurance term and actually clinical space term, medical space term that it's really stereotype and judgmental towards individuals that might not have the resources to comply with some of the recommendations of their providers. But I think that's what make the work that we do so important, right? And I always call it the work of the heart because it requires us to really see individuals as human beings and not just an individual on our caseload, right? Because it's not just those presenting issues, right? We got to think about those environmental issues and the conditions outside of those presenting issues that led to those presenting issues and those that are hindering them from, making great progress. But I mean, I don't want to digress. I have related the material compiled in this presentation to the population of focus for right in housing. But let's look at it at a high level and general definition of, well, we got some folks coming in still. This is awesome. High level general definition of stigma. Stigma refers to the negative perceptions and attitudes that society holds towards individuals or groups based on their specific characteristics, such as mental health conditions, physical disabilities, or societal identities. And these social identities, it's really like an umbrella term for, race, ethnicity, socioeconomics, and all those other things that really are part of our identity, yet for some people in society is how they sort us. The types of stigma are public stigma, the negative attitudes and beliefs that society holds about particular groups, often perpetuated by media portrayals and cultural narratives, movies, music, politics. Self-stigma, when individuals internalize public stigma, leading to feeling of shame and diminished self-worth. And then we also have structural stigma. These are the systemic policies and practices that disadvantage certain groups, such as inadequate mental health services or discriminatory laws. The term originated back in ancient Greece, where it described mark burned into the skin of slaves or criminal significantly or signifying, I'm sorry, that they were blemished and should be avoided. Are there any other historical examples that you might think of or might come up for you of when individuals were, marked as blemished or scarred or no good? I mean, even though that's not the best term to use for just for the context of getting an example. LGBTQ plus community, definitely. Oh God, yes. This is a good one. The transphobia, homophobia, definitely. Got the Palestinian genocide and racial cleansing, right? That it's actively happening in the Middle East. Slavery, yes, just because of the color of their skin, right? The Holocaust, that was the first in our history, right? First racial cleansing or genocide. I just seen the HIV/AIDS epidemic among LGBTQ plus. And I just think of, and this is a Daisyism, right? I take accountability for that. I should write a book on Daisyisms because I got so many. But when we think of harm reduction, right, people often go straight to keeping people safe from, STDs or or I'm sorry, not STDs and HIV/AIDS, right? Or keeping people safe from overdoses and in terms of the population who struggles with a substance use, right? And the reality is that we've been practicing harm reduction probably even before HIV, where we had childbirth vaccinations, right? Where we had prenatal vitamins, where we've had, medical tools and or practices to help reduce certain harms to our physical health. But because harm reduction was really got a movement, right? A big, nationwide movement around the HIV epidemic back in the 80s, then people automatically associate harm reduction to either, HIV or substance use. But I mean, I want to hope people brush their teeth every day so they reduce tooth decay, right? That's harm reduction. Wearing skincare and drinking vitamins and those kind of things. People being moved to leper colonies. Oh God, there's so many examples. Thank you all for sharing. See, this is how we all learn together. Thank you for sharing. And I'm going to move my slide and then I'm going to lose my chat again. So if anything comes up while I'm sharing my slides here, I'm going to tag in Caroline for some support. So how are we sorted, right? This concept of us versus them. Something that fuels stigma in society is the us versus them concept of social stratification, which is a system that categorizes individuals into different social classes based on various factors such as wealth, income, education, family background, and power. And when we think of, I'm just going to leave it there. I don't want to get all controversial. But these categories create distinct layers within society, within individuals at the top having more resources and those at the bottom having fewer. But I don't want to get political, right? When we think about that 1% individuals who have less access to, certain resources, it's probably the best example. And I think that currently in our society in the United States, right? we we can see that in that social stratification in many examples that we're dealing with right now or working through in the United States. So to understand stigma, we start by understanding that when we use stigma to achieve an end, we sort and are sorted ourselves based on these characteristics or differences. When the sorting includes an evaluation of someone's social worthiness, it becomes a stigmatizing action. In our society, one of the ways we are sorted is by whether we use substances or not, or whether we have a mental health or not, whether we're experiencing homelessness or not, whether we have a felony on our records, or even a misdemeanor, right? Those were categorized differently as well, right? I think that unfortunately, still, even within the community active and use individuals, right, they're separated, right? Or sorted by, oh, I don't use those hard drugs, or I don't use intravenously, as if one substance use is better or worse than another. This sorting is not done in isolation, but almost always intersects with bias and structures of discriminations based on race, class, gender, migrant or immigrant status. Purpose is to separate us from them, right? We're at a different level than them. And I'll use a lot of these, right? But to understand stigma more fully, we need to understand a working definition of it along with a description. And I want to tap into, that working definition that we already went into, and I can go back to this one, right? That refers to those negative perceptions and attitudes, but it still speaks to all three of the components because they can all be identified and such. So what does stigma exist, or why does stigma exist? Often people avoid or delay seeking treatment due to concerns about being treated differently or fears of losing their jobs and livelihood. And going back to what I shared, right? When we, don't do that internal self-work is when we can really impact the populations that we work with, because of that lack of understanding. It creates a fear and a misunderstanding, as well as the bias of this population that we're working with. Oftentimes folks that work in human service have this relatability, right? They've been through something in life, or their family members, and they want to, be the change, right? Also, misleading representation. Media can exacerbate negative perceptions, leading to widespread discrimination, right? Unfortunately, media, like I shared, movies and music can really create these negative perceptions for individuals. But when we show up for folks, right? Human nature has this way, our genuine self, right? Has this way of speaking to us without words, right? It speaks to us through feelings and behavior responses and those kind of things. When those come up and we don't really check them and really do that self-reflective work of, why am I feeling this way? Why am I behaving this way? And then this is what causes us problems, because stigma, prejudice, and discrimination against people with mental illness, and I'm going to often, reflect back to people experiencing homelessness, people with managing symptoms of a mental illness, and or people managing symptoms of a substance use disorder, or even people managing symptoms of a trauma, right? Because sometimes even trauma responses that an individual might not be aware of, that this is they're responding in such a way because of their trauma experiences, can really create this negative perception of that individual for providers. And then there's these societal norms, right? And even cultural norms, community norms, that if an individual is not aligning with our values, traditions, or certain behaviors that we do, or certain behaviors that we don't do in certain communities and cultural groups, then these individuals become stigmatizing and labeling. In my I know, at least in my home, right? Growing up with, old school grandparents that, survived many natural disasters and experienced the ramifications of having a low income, their perception of those different substances was a negative one. The perception of, people who were experiencing homelessness was also a negative one. Um, and those are just some examples. And I'm always I'm comfortable in being transparent with my own experiences, right? Because they've really shaped me and have enforced that need for me to really self-reflect on how I'm showing up for people, and how, when I'm interacting with people, some of the feelings and behaviors that I identify can impact others, but knowing why I'm having those feelings and behaviors is most important. Harmful effects of stigma and discrimination can contribute to worsening symptoms and reduced likelihood of getting treated, right? Because, like I shared in the beginning, seeking treatment because of is hindered because of some of the experiences they have had around stigma and bias when seeking support from providers. A recent extensive review of research found that self-stigma leads to negative effects on recovery among people diagnosed with severe mental illness. So going into a provider and feeling stigmatized and biased, right? We internalize that. And then that really impacts how we reach out to other, follow up with providers, engage with providers as well. Effects can include reduced hope, low self-esteem, increased psychiatric symptoms, right? The increased sense of hopelessness and loneliness, the anxieties, right? Those worries, difficulties with social relationships, right? Now we don't feel part of social citizenship per se, where we are part of our society or our communities. Um, Reduced likelihood of staying in treatment and engaging in treatment, and more difficulties at work if an individual is employed. In a 2017 study involving more than 200 individuals with mental illness over a period of 2 years, found that greater self-stigma was associated with poorer recovery from these, mental health symptoms that they were experiencing after 1 and even 2 years. Stigma not only directly affects individuals with mental illness, but also the loved ones who support them, right? Often having to kind of stand up and advocate and educate folks, right, around some of those misconceptions or negative perceptions that they have of our family members. I remember in my early recovery, I would, and being educated on the power of language, right? And going to family activities. And in the Latino community, well, I'm only going to speak for my family. They're special. I absolutely love them all. But in my family, they will use a term that we say in Spanish that it's the same as addict, right? And I would always correct my family members in the beginning, right? And be like, so do you mean people who are actively using or active users or people experiencing substance use? And at first they were like annoyed with me, right? And they were like, oh, now you're the recovery person. Now you know everything, yada, yada, yada. And now, like, when it slips up and we're around, they're like, oh, I'm sorry. I know you don't like that term. I'm like, it's not that I don't like that term. I don't like the term, but it's how we empower other folks and what messages we're putting out, right? So now they're getting hip to me and they like correct themselves and are mindful in how they speak around me, which I hope they're also doing it when I'm not around, right? But it speaks to those negative perceptions that can impact our family, and then our family impact other people. And so in doing the work, I feel we often say, don't take the work home, but I think that I've found a nice, beautiful marriage between my family and my work, and I'm able to share nuggets to help dismantle dismantle some of the stigma and shame that we can use just through language. Individuals understand, perceive, and define stigma and its impact in various ways. When it's applied towards an individual experiencing a mental and/or a substance use disorder, the target and the impact of it often includes the family members as well. The association is known as courtesy stigma, And it means that sometimes family members and those associated with persons with a mental health disorder or substance use disorder experience avoidance by others because of the stigma. And this is why folks want to keep mental health and substance use challenges in their families a secret, right? And then there's this other concept or idea that culturally, right, some of these disorders might be how they see it might be already stigmatized or stereotyped, right? I remember growing up and my uncle telling my when she was having a rough day, oh, did you take your meds? Oh, you're going through a therapist. Are you crazy? Right? And those things and being as a teenager growing up, I really didn't understand this idea of my aunt being crazy because she was on meds or she's seen a therapist, right? And then I became a therapist. But before becoming a therapist, I seen the value it had in my life, right? And although it's one of many multiple pathways for substance use and mental health, it's important for us to, kind of normalize it, not just in our work, but also in our families to dismantle some of these negative perceptions because they will be perpetuated, right? Courtesy stigma can play a more insidious role in mental health and addiction services. Organizations may receive less funding because of the type of services they provide, and there's often less support money. I think that currently our society here in America is going through this, right? Where a lot of services and funding for services is being, and this makes me emotional, is being cut because of a perception that is had about certain population and certain population needs. Um, and I wish that we had, folks in more powerful positions to really, value what the data research says and that we've had for decades around the need to support certain populations that are, you know, don't have the same access that everybody has. So it's a tough time in our country right now, and I think that us continuing to do the work that we're doing and supporting the folks that we support, whether in housing services and mental health services and substance use services, is the best way that we show our humanity and work towards this dismantling of the stigma and stereotype around some of the folks that are going to be directly affected by some of these cuts. Um, we live in interesting times right now, and so with that said, if you all need to take a moment, because I sure do, I'll just take a deep breath because I feel like lately I've been really emotional in certain meetings, and I don't want to apologize for my humanity, but it just shows that many of us are impacted, even in good positions, are impacted by some how our the people that we serve are impacted by some of these changes. Stigma also perpetuates often irrational and unfounded fears about individuals' challenges with mental health and/or um, substance use. Now let's look at bias. Oof, that was tough. I thought I was going to break down crying. Let's see here. Let's look at bias. And let me just preface, I'm sorry, with saying that bias do not make us bad people. They are shaped by our life experiences. And I shared this in the beginning for those of you who weren't on the call in the beginning. And these experiences, which can be influenced by many sources, right? Direct experience, secondary experience, social media, regular media, reporting, other things like radio and movies, like I've mentioned previously. When we do not do the work of self reflection, essentially, why am I feeling or thinking this way? We do not do that internal work or the self reflective work. This is when we impact how we show up for individuals and most definitely a factor in our own burnout, right? So let's just dive deeper here. And I just want to be mindful of time. So, bias is a tendency or inclination that affects judgment, leading a person to favor or disfavor certain ideas, individuals, or groups, often in an unfair or unbalanced way, and maybe even irrational way. Biases are often unconscious and can influence how we perceive, evaluate, and interact with individuals. The different biases are implicit, which is subconscious and automatic, right? Explicit, conscious and deliberate. Positive, favoring someone or something. Negative, prejudice against someone or something. Bias are often based on stereotypes rather than actual knowledge of an individual's or their circumstances. Whether positive or negative, such cognitive shortcuts can result in prejudgments that lead to rash decisions or discriminatory factors. Um, and practices too, right? And how we engage with folks or do the work that we do. Starting at a young age, people would discriminate between those who are like them, their in group, and those who are not like them, that's the out group. On the plus side, they can gain a sense of identity and safety. However, taken to the extreme, this categorization can foster an us versus them mentality and lead to harmful prejudice. So, why does bias exist? Discrimination against, right? The in group versus out group mentality, learn and dependable, socioeconomic status, race, ethnicity, educational background, etc. And then those cognitive errors from repeated patterns of thinking. It is often learned and is highly dependent on variables like a person's socioeconomic status, race, ethnicity, educational background. At the individual level, bias can negatively impact someone's personal and professional relationships. At a societal level, it can lead to unfair persecution of a group such as Holocaust and slavery. Just for example, I remember doing a diversity course during my social work studies in my bachelor's level. And one of our assignments was going to public spaces and observing how people group themselves, right? Like going into our cafeteria, seeing how students sit together, right? Seeing how students sit together in classrooms or in libraries. And what we found in those exercises, and I remember people having examples of groups of people at churches, groups of people at like bus terminals and train stations, and groups of people in the workspace and those educational spaces like cafeterias, libraries, and those kind of things. And they found that people do also group themselves based on who they know, right? Or who they can identify with, right? So racially, groups were separated racially, groups were separated based on what degrees they were or what program they were in the school. And these were groups in the library and then the cafeteria based on, they will group themselves based on what extracurricular activity or sports they played, right? So it created categories for individuals. So a category of bias known as cognitive bias are repeated patterns of thinking that can lead to inaccurate or unreasonable conclusions. Cognitive bias may help people make quieter decisions, but those decisions are always accurate based on their internal perceptions of groups of people. Some common reasons why include flawed memory, scarce attention, natural limits on the brain's ability to process information, emotional input, social pressures, and even aging. When assessing research, even one's own thoughts and behaviors, it's important to be aware of cognitive bias and attempt to counteract them to eliminate its effect or minimize its effect on, those out groups. Any thoughts or questions so far? Okay. So bias affects family and society in several significant ways. Personal relationships, bias can lead to unfair treatment and judgment, affecting how individuals perceive and interact with family members and friends. For example, implicit bias can influence how parents treat their children based on stereotypes. I remember when I was actively going to a family event, and one of my cousins, like, was in the kitchen and she walked to the living room where the front door is and picked up her purse from the couch. So in my head, I was like, is she thinking that I'm like gonna steal from her or something, right? And so that kind of made me feel some type of way, and I was uncomfortable the whole time I was there. We have these cultural stereotypes. Biases often manifest in cultural stereotypes, which can shape how families and society view different groups. This can lead to discrimination and systemic inequalities, affecting the treatment of individuals based on their identity. Now, thinking on how it affects families and others, right? We also have to think about these families and others. They also go into workspaces and bring those beliefs and those stereotypes, right, with them to these public spaces or workspaces. It affects decision-making. Bias can distort decision-making process, leading to unfair judgments and choices. For instance, in healthcare, implicit bias can impact how well a patient is treated based on their race or gender. It can affect how patients are treated based on their diagnoses, right? One thing I learned through my work in both peer and clinical spaces is, how we describe individuals' needs and challenges, right? And in the clinical space, what their diagnoses are. And, I practice due diligence and, I'm like, nail and cuticle with my supervisor around diagnoses, right? Especially for individuals of color, for women of color, and men of color who, often are diagnosed with certain diagnoses that carry them through life and create a perception of them with other providers. Social dynamics is also another effect on family members and others where bias can create another us versus them mentality where individuals are more likely to accept ideas that reinforce their beliefs and reject those that challenge them. This can lead to a mindedness and missed opportunities for growth. I unfortunately have experienced this in previous professional spaces where I felt like I've always been super transparent about my lived and living experience and my accountable commitments or commitments to accountability to the DLC, right? And I always felt like, and I learned this recently, that there can be this education bias where people might think that, or have this stereotype or this idea that because I have lived experience and I was an active user at some point in my life, or I am a felon, that they feel intimidated by the fact that I now have education and would push back on some of my feedback and or some of my ideas when working on teams. I'm really lucky and blessed to be working at C4 where, um, our experiences are a badge of honor versus a scarlet letter, right? And where we're all treated equally, equally contributing to the progress and success of our teams, independent of what our lived or living experience might be. But this is real stuff that happens in work cultures that really affects the dynamics of teams and essentially the progress and the success that they can establish through being inclusive and diverse and not just race, ethnicity, and gender, right? Or sexual orientation, but also in life experiences, education, and those other things. Biases can become problematic when they marginalize and exclude others, and it can shape behaviors, decision, and outcomes across all areas of life, from hiring and education to healthcare and social interactions. Recognizing bias is essential for promoting fairness, equity, and objectivity. And bias can impact the services we provide and can be influenced collectively as well. Now we'll jump into the impact of stigma and bias as a whole, specifically on the population of focus for Rhode Island housing. Impacts of individuals experiencing homelessness. I did look up some data here. In fact, for all my Crossroad attendees, shouts out to Crossroads. They has shared in their website that each year about 4,000 men, women, and children experience homelessness in Rhode Island, all right? And that's per se an average, right? Because we also have to consider those individuals, right? There's experiencing homelessness could look different for everyone, right? An individual can be unhoused, an individual could be, sharing housing, or as we would call it, couch surfing, right? Or an individual might have limited or low financial resources to support stable housing and live in transitional spaces. But that was the data from Crossroads. And then the US Department of Housing and Urban Development back in 2023 recorded a high 653,104 individuals experiencing homelessness in the US, representing a 12.1% increase from the previous year, and attributed to the various factors, including rising housing costs and the COVID-19 relief programs. The weight of anti-homeless stigma and oppression that render them seemingly invisible yet vulnerable to acts of violence, restrictions on the activities related to homelessness, sexual assault, exploitation, and human trafficking. The stigma, and it's important to also talk about the trauma when we think about being housed and then having to transition to not being housed. And, the trauma that leads to that, right? But then the trauma you experienced during this period, experiencing homelessness to then being housed again, right? It's many um, contexts that we have to keep in mind. The stigma reflected in general society's city legislation, law enforcement, and even the healthcare system dramatically decreases the quality of life of homeless individuals experiencing homelessness. I'm sorry, and further marginalization or ostracizing as a population as a whole, and the struggles with meeting the basic human needs of food, clothing, and shelter. These anti-homeless sentiments date back centuries in America to before the birth of the nation, and historical anti-homeless ideologies dating back to colonial times can be found in modern interactions of legislation and societal attitudes towards individuals experiencing homelessness today. Individuals may experience homelessness. They're 3 to 4 times more likely to die prematurely than general population. And if they also have these also co-occurring needs, right, where they're experiencing homelessness, but they're also experiencing or managing symptoms of their mental health and or managing symptoms of the substance use, that also decreases the lifespan, right, of individuals. It's important, right, to also highlight, right, that when reflecting on marked disparities in health outcomes for this population compared to the general population, if the general population already has, health disparities, right? Those health disparities for individuals who are experiencing homelessness are greater with a less positive outcome. The key factors contributing to homelessness, to individuals experiencing homelessness, and feel free, because in this case, y'all are the subject matter experts. If I'm missing anything or if I have anything wrong, feel free to, correct me on it so that we could all learn together. But the key factors for contributing that contribute to individuals experiencing homelessness are lack of affordable housing. The rising cost of housing coupled with stagnant wages makes it incredibly difficult for low-income individuals and families to secure stable housing. Many cities report that housing costs far exceeds what low-income earners can afford. That, individuals in lower economic status who are experiencing, the ramifications of poverty, economic instability, and poverty are significant contributors to homelessness. Individuals living below the poverty line often struggle to afford basic necessities, including housing, food, and health care. I have a client who often says, always got to steal from Peter to borrow from Peter or steal from Peter to pay Paul or something like that. And I find it, so relevant. It makes so much sense, right? Do we pay my rent in full, or do I take out my medication that has $125 copay, right? Unemployment, job loss, or the inability to find stable employment can lead to financial crisis, making it challenging for individuals to pay rent or mortgages. Unemployment rates can significantly impact homeless rates in various regions. And mental health issues or mental health disorders. Many individuals experiencing homelessness suffer from untreated mental health disorders, which can impair their ability to maintain stable housing. The lack of access to mental health services exacerbate this issue. I shared in last session that we had an experience that I had while I was going through my associates, where we had to do various practicums or internships. And I remember talking about how I couldn't understand how males were homeless or men were homeless, because despite the dysfunction and the trauma and the chaos in my own home growing up, the men in my home, my grandma, my grandpa, and my dad, they were head of household, right? They really financially held the house together and ensured that, I would go to sleep without a refrigerator and wake up without a refrigerator because my mom sold it in the middle of the night, right? And that's just me, being transparent and vulnerable, to use this example to connect it to the mental health, right? Um, and so my mom, dealing with her own substance use and her own untreated mental health, really created many difficulties in our lives. But our men in our lives really picked up the pieces all the time, and I couldn't understand it. So I remember my professor, I didn't have a choice that semester. My professor assigned me to a men's homeless shelter. And I probably learned the most and really changed my whole perception, right? And this is my own stereotypes and stigma and bias because of the danger of a single story. The men in my home really try to keep everything together when things were falling apart. And so that's the only example that I had in my life, right? But I learned it working at this homeless shelter, the amount of veterans, which is preposterous to me, the amount of veterans that are experience homelessness and some of the needs that they have, right? That PTSD, that mental health, untreated mental health needs. And because of those needs that they have, being disconnected from families and or burning bridges with families that wouldn't support them, and so they end up homelessness. But it was probably the most life-changing practicum or internship that I had. Then we also have some of the factors here is substance use. Addiction can lead to a cycle of instability, making it difficult for individuals to keep jobs or housing. Then we had people experiencing violence in the home or in relationships, especially women and children flee abusive situations and find themselves homeless as a result. I learned, at least in doing this work, that in Massachusetts, we only have about 11 um, shelters or safe housing for women and children who are experiencing, who have this experience of fleeing a violent home, which doesn't even meet the need, right? Systemic inequalities, discrimination based on race, gender, and sexual orientation can limit access to housing and employment opportunities, and disproportionately affecting marginalized communities. And this also speaks to individuals who have a criminal record, right? And how they might be ostracized from applying for certain housing based on what charge they have. A population that is often ostracized in these systems is individuals with sex offense or individuals who have an offense around fire, right, or setting arson. And despite those populations being underserved, right, because of these systemic inequities where they're perceived a certain way. But it's important for us to really, when we think about equity and inclusion, being equitable and inclusive to all, independent of what their cores reflect. We have health issues, right? Chronic health problems can lead to financial strain and loss of employment, contributions to homelessness as well. The high cost of healthcare is an absolute mess right now. Some housing landlords having this requirement of 3 times my rent. If I had 3 times my rent, I would probably buy a house, right? Instead of renting a rinky-dink one-bedroom apartment in probably an unsafe neighborhood, those kind of things. Lack of support systems. Many individuals experience homelessness, lack familiar or community support, which it can exacerbate their situation and kind of irrationally validate this idea of hopelessness, not being worthy, like I'm not good enough, and fuel isolation from family, friends, and community support. And then there's natural disasters, events such as hurricanes, floods, and wildfires can displace individuals and families, leading to increased homelessness. Understanding these factors is essential for developing effective solutions to address and alleviate homelessness. And then also really understanding and leaning in with this posture of service and this posture non-judgmental and compassionate care, right? To create spaces for folks that even when they're not ready to follow through with certain steps or the conditions are right, or they don't have the resources or the support to follow through with some of the recommendations, that they're still doing the best that they can, and being, support in however way we can, right? Allowing the individual that anonymity to choose and make decisions based on how we inform what resources are out there to support their needs. So what does the data say? The bidirectional relationship between mental illness or mental health and homelessness has been the subject of countless reports and few misperceptions. The failure of deinstitutionalizing back in the 60s, where psychiatric hospitals were, you know, deinstitutionalizing individuals, led to far too many psychiatric patients being co-signed to groups, um, like group home, residential home, shelters, the streets, and we see it now even in carceral settings, right? How we're incarcerating mental health. I'm a member of the Justice Involved Women's Panel in the state of Massachusetts, and it has representatives from different branches, including an individual with lived experience. And I remember recently the director of the DOC that's retiring after 40 something years of being a director, she has shared how now she has noticed in the population that is, completing commitments, accountable commitments to the DOC, that have SMIs, not just mental health, right? But severe mental illnesses. And she also sees those generational connections where in her early career, she would see the parents, individuals that are going through the doors now with some of these SMIs. And the JAMA Psychiatry published a study finding that 67% of people experiencing homelessness worldwide have a mental health disorder, and the prevalence of mental health disorders among this populations appear to be on the rise. Although the prevalence of mental health disorders among people experiencing homelessness was 67%, while the lifeline prevalence was 77%, additional findings included that North America had the highest prevalence of mental health disorders among people experiencing homelessness at 77%, compared with Australia at 47%, Asia at 59%, and Europe at 60%. Males experiencing homelessness had a significantly higher lifetime prevalence of mental health disorders at 86%, compared with females at 69%. And then we also have to consider, right, although this is just gender, right, gender orientation, especially youth, right, where youth who are members of the LGBTQ plus community experience homelessness at a higher rate than regular youth, or youth that are aging out of foster homes. Some of them really prefer experiencing homelessness and just figuring their life out than staying restricted to the system. And so, also do go, back home where their family of origin, but not to their own stable housing. Also, antisocial personality disorder, when it comes to mental health, antisocial personality disorder was the second most common disorder with a current prevalence of 26%, followed by major depression at 19%, general mood disorders 18%, anxiety disorders 14%, psychotic disorders 14%, post-traumatic stress disorders 11%, bipolar disorders 8%, and schizoaffective disorders 7%. And I've kind of grouped psychotic disorders, post-traumatic stress disorder, bipolar disorder, and schizoaffective disorder with SMI, which represents majority of the individuals that are experiencing homelessness. Substance use disorder, including alcohol, were by far the most prevalent disorders identified, with a current prevalence of 44% and a lifetime prevalence of 56%. Any thoughts or anything come up with, oh, I just noticed my image blocked the E and my the, but any reactions, thoughts that might come up with some of these numbers? Do you think they're about accurate? Do you think they're underrepresented? I don't know what comes up for you all and seeing these numbers.
I have a question.
Absolutely, go right
Do
ahead.
do the numbers reflect the resources available, like sort of like North America versus other parts?
No, so JAMA Psychiatry published a study based in North America, so just the US, and the prevalence of certain disorders and factors, the resources. But you
Okay.
make a good point because, right, some communities are underserved when it comes to resources, right? When we think about rural communities, right, and how many barriers they have in seeking or accessing services. When we talk about individuals that speak other languages than English, right, that's another community that has real barriers in connecting to resources, independent of that human right of, accessing services and materials for services in our native language. Good question. Yes, redlining is still a real thing, and not just in home buying, right? But also in renting. Thank y'all for sharing those thoughts and the question. So we'll now jump into stigma and bias in relation to internalized stigma and the disconnection to self that is impacted by stigma and bias. And it's important to consider, right, that genuine self is not just how the individual's genuine self, but ours as well, right? Because like I shared previously, there's like this non-verbal alarm system that our human self has developed that lets us feel and think and behave a certain way when things are not right and we notice things are not right. But let's jump into that. Oh, I try to be all cool with my animations and always forget where I put them. So stigma and bias significantly impact individuals' perception of themselves, often leading to internalized negative beliefs. In in our in the professional space, you ever heard of the oh God, oh, what's that term? Yes, right on, imposter syndrome, right? That happens to us, right? And that's how we internalize some of these self stigmas and negative stigmas that we receive, or public stigmas that we receive, messages that we receive from the public, right? So stigma can result in emotional distress, loss of self-esteem, and mental health issues, as individuals may feel unworthy or inadequate due to the perceived flaws. And some of those messages we internalize. And it affects how we show up for folks, but it also affects how folks show up for us, right? And how they stay engaged in the support services that we provide. Um, Research indicates that stigmatized individuals often experience social distance from others, all right? This is going back to not feeling like we fit in, the them versus us, or us versus them. The concept of self-stigma is not merely a relief identity. It can be influenced by various factors, including societal stereotypes and personal experiences, which can shape how individuals perceive their identity and their place in their communities, right, or the world or their workspaces. Both public stigma and self stigma are characterized by stereotypes, prejudice, and discrimination, which can create barriers to recovery and empowerment for those individuals that are affected. The consequences of self stigma can be profound, including increased depression and reduced self-esteem. It also highlights the need for understanding and addressing these issues, right? And kind of, you know, this loving and radical accountability of calling people in to help me understand why you mean by that, right? And also, giving and sharing positive affirmations and celebrating, small achievement and small goals for individuals that we're working with, as well as our colleagues, right? So that it can help dismantle some of those internalized messages that we internalize. And understanding this as dynamic is crucial for fostering a more inclusive environment and promoting genuine self-acceptance for both individuals that we serve and ourselves, of course. So just going over a little person first language, it's a growing body of literature demonstrating that healthcare providers use stigmatized language with speaking and writing about patients. And that I've learned that doesn't go just in the healthcare settings, but also in behavior and mental health care settings. And as workers in those settings, the words we choose in our clinical communication frame narratives about patients and their experiences can really impact the people that we serve, and even affect our colleagues if someone else is reading it and they identify, some of these languages, some of these terms that we use. Through our language, we can transmit messages to each other and to our patients about identity, agency, and blame. I always say we can speak life into people or we can speak death into people, right? What do we choose, and how are we being intentional on how we speak to folks, right? At its best, our language can humanize, empower, and build trust. And it's at its worst, it can exacerbate disparities for some of those groups that are underserved and have high needs. Person first language is a way to emphasize a person and view the disorder, disease, condition, or disability as one part of the whole person. Describe what the person has rather than what the person is. Person first language avoids using labels or adjectives to define someone. An example is a person with diabetes, not a diabetic, or a person with cancer, not a cancer patient, or a person with bipolar disorder, not a person who is bipolar. Some communities, however, prefer identity first language because they consider some characteristics as inseparable parts of their identity. Excuse me. Those who prefer identity first language consider it a way to show pride in who they are in their membership in a community of similar people. The deaf and autistic communities, or communities of individuals with deaf and hard of hearing needs, or individuals who have needs because of an autism diagnosis, for example, often show a strong preference for identity first language. When people ask if a person or group use identity first language, like a deaf student or person first language student who are deaf, default to using person first language if preference is not known or it cannot be determined for some reason. It's moving, little chart that I put together here is moving from to, for example, what is wrong with you to what has happened, disproportionately affected or vulnerable groups to population of focus, under-resourced community, health disparities to people with lower economic statuses, intimate partner violence, domestic violence to people experiencing violence in the home, the homeless, people experiencing homelessness, poverty stricken or the poor to people with lower income resources. Any other examples that you'd like to share or add, please feel free to do so. You can unmute yourself or share it on chat. One that I'm looking to transition is a person who was incarcerated, which I'm looking an individual who successfully completed an accountable term to, but I'm still working with it because I feel like, this is ever changing. And then we find that, people like feedback a certain way. And when we really, lean into that anonymity, right, for the person to make their own choices. And we can ask, what terms, because there's so many euphemisms nowadays, right, that folks should have the freedom to choose how they want to be um, identified or how, they like feedback and whatnot. All right, so let's work through our little vignette here. So CS is a 58-year-old individual experiencing homelessness. He presented to the emergency department and was found to have cellulitis. He was prescribed doxycycline and discharged. He had 2 recent ED visits for hyperglycemia because he was unable to secure an outpatient clinic appointment at the local healthcare center. He had mobility challenges due to neuropathy and lack of reliable transportation. The medication order was not on the formulary for his insurance, and he could not afford to pay cash for it. So it took 2 days before he obtained an alternative. He returned to the hospital when the cellulitis worsened, as instructed by the physician. He declined admission to intravenous antibiotics because he was concerned about missing work he just obtained. The next day, he logged into his electronic health record and read the following note. The patient is a non-compliant diabetic who failed oral antibiotics. He claimed the pain is so bad, but adamantly refused admission. He's a frequent flyer, so he'll likely bounce back when it worsens. He signed out against medical advice. What are some nuggets reflective of stigma and bias in the language here? In the note, we're looking at the note that he reviewed on his patient portal. That frequent flyer is a big one, definitely. Just the term diabetic. Non-compliant drives me bananas. Anything else on here that stands out for you as right? And so being conscious, judgment without having all the facts, definitely, right? Definitely. Because it's not that he didn't want to be admitted, right? It's that he had to choose between his health and his new job. Great point. Right. And this is just an example for us to really be mindful of how we um describe the people that we serve on our documentation and the way we communicate about them to other individuals, our colleagues, our supervisors, collaborating organizations. Now let's look at some strategies, and I'm just being mindful of time and respectful of your time to build practice of inclusion and excellence through these practices. So on the These are everyday actions for bias and bigotry and validate the worth and dignity of others. Interrupt, interject, disagree, point out, ask for clarification, support the person being harmed directly. Collaborate, work directly with folks with lived and living knowledge to develop strategies and next steps for addressing folks and changing the culture. Uh, an invite must be genuine and give time for individuals to process. Also, advocate, implement, or advocate for trainings, resource sharing, policy change, cultural change, value centered conversations, program change, practice change, materials, and community engagement strategies to change. And then some equity centered action steps are expect lack of closure. It's a journey, right? Now for grace, right? As individuals begin to gain this awareness of the impact of their words, behaviors on other people. Ask for clarification. That's my big one. And I always lean into my social work hat. Help me understand. What are you really trying to say, right? In the most genuine and positive and humble way that I can, so that I'm not misunderstanding, or because of my own past traumas, I'm not trying to, like digress these feelings into something that's really not happening. Embrace discomfort, right? Stepping into your vulnerability to really, hold accountability. Accountability is kind, as I shared in one of my blogs here. I know all experiences and expertise both come in many forms. I often say, when we're working on policies and procedures that are going to support a certain population or an agency, how will that impact men? How will that impact children? How will that rule impact adults? Whoever's going to be coming through our doors, how does it impact them on an individual basis, right? To ensure that it's inclusive of all. Safe and brave space, creating opportunities on teams, on in homes, in workspaces, to talk about, some of those feelings that come up. Revisiting welcome. So when, something happens, leaving that door open to really revisit the conversation when you see, people are digressing. Affirm and give credit, validate folks for their efforts and appreciate them for trying. Listen to understand, even if we don't agree. Be accountable for impact of our words, actions. Accountability is kind as we grow in awareness. Be gentle with yourself and others and give yourself grace and offer others grace, right? Now, when it's repetitive and it continues to happen, then there's got to be a point where we're holding folks accountable. And although holding folks accountable is uncomfortable, it helps the individual gain awareness and it also helps us grow in that working relationship. And we cannot challenge what we cannot acknowledge. So that self-reflective time, right? Like I said, that nonverbal alarm system that we have, that our feelings and behaviors really say something to us. um, pay attention to that, right? And do that internal self-work. And I always like to close with a quote relative to the conversation. Being homeless is like living in a post-apocalyptic world. You're on the outskirts of society. And this is by Frank Dillon. Delane. And that's my information. And if anybody has any questions, you can for sure reach out to our Rhode Island Housing or Caroline on our team. Oh, right on, 1 o'clock. Great. Any final thoughts, questions? I do just want to, share. Thank you all. I do want to share, be on the lookout, right, for registration for the October training on Housing First, which will be covered or led by our subject matter expert housing, John Cox.